Hello everybody, Dr. Alex Vasquez coming to you live right now to talk about part number 6 in this series on pharmacology that I started last month, the pharmacology of vitamin B12. As some of you know who have seen the previous videos, I eventually changed the focus of this topic from pharmacology to metabolic detoxification, and right now I want to talk to you about methylmalonic acid and how that relates to B12 as a model of metabolic detoxification. So let's start by talking about the basic physiology and pharmacology, starting with the absorption of vitamin B12. So obviously we start with acquisition, mastication, digestion, which requires the parietal cells in the stomach because they secrete hydrochloric acid and intrinsic factor. We then have to have pancreatic enzymes. We need to have a good eubiosis and avoidance of dysbiosis within the gastrointestinal tract, specifically no small intestine bacterial overgrowth, and a good ileum that's not affected by surgical resection, Crohn's disease, celiac disease, or small intestine bacterial overgrowth. From there, we absorb B12 in the terminal ileum, and we can use high-dose supplementation, typically 2 to 6 milligrams per day of vitamin B12, or we can use injections, either intravenous, subcutaneous, or intramuscular. Now we've got B12 in the blood, and the biologically available form of B12 is called holotranscobalamin, and that indicates that it's B12 bound to the transcobalamin protein. This enters the cells through a transcobalamin receptor and then enters the lysozyme, which removes the transcobalamin protein, leaving us with unbound cobalamin. Now you can see here that I've also indicated certain proteins that function as transporters, but they also have a little bit of enzymatic activity because they actually change the form of vitamin B12 as well. So mostly they're transport proteins. Some of them have a little bit of enzymatic activity as well. So again, once we have B12 inside the cell, after it's been received by the transcobalamin receptor, it enters the lysozyme so that the transcobalamin protein can be removed. Now we have B12 being transported by these transport proteins that have a little bit of enzymatic activity. The most commonly mutated of these proteins is called CBLC. And at this point, the B12 molecule is going to take one of two routes. The first route that I've indicated here is the conversion to methylcobalamin, which is required for the enzyme methionine synthase, which plays a part in the folate cycle, but also, of course, plays a part in the methionine cycle, because our goal is to get rid of or recycle homocysteine. So homocysteine, as you should know, is neurotoxic, vasculotoxic, and osteotoxic. So we can see that this is a metabolite, a toxic metabolite that has to be detoxified through the provision of adequate nutrition, in this case, folic acid, B12, B6, betaine, and at times, acetylcysteine or N-acetylcysteine. What I want to focus on right now in today's presentation is the metabolism of events that occurs up here, and so let's dive into that and take a look. So the other route for B12, other than getting converted into methylcobalamin, is its conversion into adenylcobalamin. Adenylcobalamin is the cofactor for the enzyme methylmalonyl-CoA mutase, which converts L-methylmalonyl into succinyl-CoA, which gets metabolized, or we might say burnt off, within the Krebs cycle or the citrate cycle within the mitochondria. So whereas the events down here are occurring within the cytoplasm, all the events up here are occurring within the mitochondria. So what I want us to focus in on is that we have to get rid of some of these toxic metabolites or these toxic intermediates. L-methylmalonyl-CoA has to get converted by this enzyme, methylmalonyl-CoA, which requires vitamin B12 in the form of adenylcobalamin. We have to get rid of this metabolite with this enzyme, otherwise it's going to accumulate into something called methylmalonic acid. For many years, we considered methylmalonic acid to be inactive, but we now know that it is neuroinflammatory, that it causes mitochondrial dysfunction, and that it also promotes tumor growth. So previously, my opinion on this lab test for methylmalonic acid is that it was perhaps overused, but certainly not necessary in the treatment of common B12 deficiency, and I still think that that's mostly true. I'll talk about that more in just a moment. But what I want us to do right now is look at methylmalonic acid not as an innocent bystander or byproduct that elevates with B12 deficiency, but rather an indicator of unwellness and unhealthy aging, specifically as it causes neuroinflammation, mitochondrial dysfunction, and promotes tumor growth. The original source for L-methylmalonyl-CoA is propionyl-CoA, which comes from propionic acid. Propionic acid is produced from the gut anaerobic bacterial fermentation of carbohydrates. Also, certain amino acids, including valine, methionine, isoleucine, and threonine, and also odd-chain fatty acids. So those are the sources of propionic acid, which gets converted into propionyl-CoA. If we don't get rid of propionyl-CoA, that's called propionic acidemia, and that can be a life-threatening condition. Propionyl-CoA carboxylase is the enzyme that detoxifies the metabolite propionyl-CoA, and this enzyme requires biotin as a cofactor. And this is why we use biotin as a nutritional supplement, is to support the activity of propionyl-CoA carboxylase to get rid of this toxic intermediate or this toxic metabolite called propionyl-CoA. Systemic accumulation of propionic acid is a life-threatening condition. So we have to convert propionyl-CoA into methylmalonyl-CoA. However, at the start of this conversion, propionyl-CoA is converted by propionyl-CoA carboxylase into the D isomer of methylmalonyl-CoA. This enzyme, methylmalonyl-CoA mutase, only functions against L-methylmalonyl-CoA. So we have to use an enzyme, abbreviated here as MCEE, which is methylmalonyl-CoA epimerase, and that converts the D isomer of methylmalonyl-CoA into the L isomer of methylmalonyl-CoA so that it can be detoxified by methylmalonyl-CoA mutase, which requires adenosylcobalamin as one of the forms of vitamin B12. So again, if a patient makes too much propionic acid because they have gut dysbiosis, they're going to accumulate propionyl-CoA, which then has to get detoxified. If the patient has a defect in this enzyme or they don't have enough biotin, then they're going to accumulate propionic acid, and we call that, again, propionic acidemia. Alternatively, if they have too much inflammation in their body and they're creating too much tumor necrosis factor alpha, that's going to reduce the expression of this enzyme, which converts the D isomer into the L isomer so that this methylmalonyl-CoA can be detoxified. If it's not detoxified through this route, then it accumulates as methylmalonic acid, which you can test with laboratory testing, and that's pretty much the emphasis of today's presentation. Methylmalonic acid was previously considered to be an inactive intermediate, and now we know that it is a toxic metabolite that causes neuroinflammation, mitochondrial dysfunction, and tumor growth. So let me show you the details and data on that. Elevated methylmalonic acid is a marker of unhealthy aging and increased disease risk. Methylmalonic acid is primarily a byproduct of propionate metabolism, as I just showed you. Deregulation of propionate metabolism can be quantitative and qualitative. Propionyl-CoA and propionic acid are sourced from oxidized cholesterol, gut microbial fermentation of carbohydrates, valine, odd-chain fatty acids, methionine, isoleucine, and threonine. Gut microbial fermentation of carbohydrates can be reduced by a low-carbohydrate diet, fasting, antimicrobials such as metronidazole, and other measures. Deregulation of propionate metabolism also occurs through the downregulation of methylmalonyl-CoA epimerase, which is the enzyme that I mentioned previously in the diagram that I had abbreviated as MCEE. Additional research, also from Ana Gomez and her colleagues, shows that MMA, or methylmalonic acid, promotes clinical cancer via several different mechanisms. It induces a pathway called SOX4, which results in transcriptional reprogramming, which, according to Ana Gomez and her colleagues, endows cancer cells with aggressive properties. She describes this as epithelial to mesenchymal transition, which is a developmental process hijacked by cancer cells to acquire pro-metastatic properties. This induces resistance to chemotherapy, increases migratory capacity of cancer cells, increases invasive capacity of cancer cells, increases tumor markers indicative of cancer aggressiveness, and causes concentration-dependent enhancement of cancer metastasis and invasion in animal models. So in conclusion, when we're dealing with outpatient adults, measuring methylmalonic acid is clearly not necessary and can be an impediment for the treatment of routine B12 deficiency, as we commonly see in patients who have small intestine bacterial overgrowth, those who are vegetarians, those who are taking metformin, which causes B12 malabsorption, and other drugs, including acid-blocking drugs. Therapeutic trials of B12 or cobalamin are warranted when clinical findings consistent with B12 deficiency are present. Failure to treat B12 deficiency that leads to brain damage and patient suffering should be considered medical malpractice, and I've discussed that in some other videos, and I'll show you how to access those videos in a few more lines. Standard treatment is intramuscular, intravenous, or subcutaneous as needed, or if we're using the oral route, that would be 2 to 6 milligrams per day of vitamin B12. And I think a good idea is to check MMA in complicated cases and after 1 or 2 months of treatment just to make sure that everything's working as we expect. But we should never delay intervention after we've made a clinical assessment of possible or probable B12 deficiency. The consequences of B12 deficiency include permanent paralysis and brain damage, so we can't run that risk. If your clinical assessment is that they have peripheral neuropathy, spinal cord injury, brain damage, depression, anhedonia, schizophrenia, catatonia, then go ahead and start them on B12, and you can test their MMA level a month after you've started treatment. If the patient has the financial means, then of course you can do the test before and after. But you should never delay treatment as a clinician because you're overly dependent on laboratory testing. If you're working with inpatient pediatrics or young kids who have failure to thrive and complex cases of any age, MMA is a common component of searching for metabolic disease. Disorders of cobalamin metabolism can present at any age with a wide range of clinical presentations, including fatigue, depression, obviously anemia, neuropsychiatric manifestations, kind of looking like schizophrenia all the way to catatonia, spinal cord dysfunction, and peripheral neuropathy. Rarely, but cases that you want to be aware of include that B12 deficiency or disorders of B12 metabolism can present as thrombocytopenia and hydrocephalus. You can see my Part 2 video review here at inflammationmastery.substack.com. But again, in conclusion for today's video, which is the most recent but certainly not the last installment on this series, is that I want us to start thinking about elevated methylmalonic acid as a marker of unhealthy aging and increased disease risk. We know that methylmalonic acid originates from propionic metabolism, which is also a toxic metabolite that we have to get rid of. So we have to get rid of propionic acid or propionyl-CoA. The way to get rid of that is through this pathway of detoxifying methylmalonyl-CoA. If we don't get rid of the methylmalonyl-CoA, then that's going to accumulate in the cells and in the entire body, the entire organism, and that's going to promote further neuroinflammation, mitochondrial dysfunction, and cancer growth. Again, according to the work of Ana Gomez and her colleagues, methylmalonic acid induces resistance to chemotherapy, increases tumor markers indicative of cancer aggressiveness, and causes a concentration-dependent enhancement of cancer metastasis and invasion in animal models. So thank you very much for your attention. Again, this was part 6 in a series that started out as the pharmacology of vitamin B12, and then I changed the emphasis of that to metabolic detoxification because what became clear is that we have to get rid of these toxic intermediates, propionic acid, methylmalonic acid, and homocysteine. Obviously, we've been testing for homocysteine for decades, and we should continue to do that, but I think we need to give new emphasis to testing for methylmalonic acid as a marker for unwellness and unhealthy aging because it causes neuroinflammation, mitochondrial dysfunction, and it promotes cancer growth. So thank you very much for your attention. This has been Dr. Alex Vasquez, and I invite you to see the other videos, parts 1 through 5, at healthythinking.substack.com or inflammationmastery.substack.com. Thank you very much for your attention.